Welcome back to the exhibit hall at Eyes on Dry Eye 2023. I am your co-moderator, Dr. Damon Durker, coming to you here from Indianapolis. Very pleased to have a conversation here with my good friend and colleague, Dr. Doug Devries. I have learned so much about dry eye, blepharitis, MGD, inflammation from Dr. Devries. We go back to the dry eye boot camp days. He's just been an essential part of dry eye education all throughout the country, internationally as well. We're going to talk about diagnosis of inflammatory dry eye with Quidel's InflammaDry. Welcome, Doug.
Oh, thank you, Damon. It's a pleasure to be with you, and I have equally enjoyed all the things that we've had the opportunity to do, and a lot of our peers that we've been able to, pass information on from, things that we've learned in companies and different products. So it's a pleasure. Thank you for inviting me.
I've got Doug's bio in front of me. It's pretty lengthy, but I'm going to hit a couple highlights. He co-founded Eye Care Associates of Nevada in 1992, limited his practice to surgical co-management and diseases of the eye. He's a lifelong Nevada resident. He is a pilot. He likes to ride motorcycles. He's a skier. He's a hiker and a marksman, and somehow he's talking about dry eye and still seeing patients. You're a busy guy, Doug.
Yeah, what you mentioned earlier was the adrenaline part of what I like to do. So
great. So let's get into it. So, we have a lot of technology, and I know you're on the forefront of a lot of this, Doug, in your clinic and what you do for your patients and what you teach to your residents and your students, as well as to our colleagues all across the country. You know a lot about new technology. What can you tell us about QuidelOrtho?
Well, QuidelOrtho has a point-of-care test that is one of the easiest tests to implement in the clinic as far as a point-of-care test goes. What it really is the InflammaDry, which is measuring MMP9s. MMP9s is an essential proteolytic enzyme to measure. And the reason it's so essential is it's a non-specific inflammatory marker. So, if your patient's eyes are inflamed, whether it's dry eye, whether it's allergy, whether it's a contact lens related issue, an infiltrate, you can detect it with a really high sensitivity and specificity, looking at MMP9s, of which the InflammaDry test measures. The other test that's available that, boy, when it hits an area, it's so essential, and that's the adenovirus, looking to see and identify the adenovirus. And in all of the different variations of that are sensitive to that particular test. And really, when we look at how you start doing that test within your clinic, there's really no capital investment other than getting a CLIA waiver, and that is a state and a federal application that you fill out, and relatively easy in most states. And then it's as simple as buy the test, do the test, bill for the test. And when you're billing for a point-of-care test, it does not affect your evaluation management code. It doesn't affect any other procedures you do. It simply is billed as a test under a separate set of deductibles for patients. In the case of Medicare, it's 100% covered to have those diagnostic tests done. So it allows you to perform and have a CLIA waive test within the practice, and then be able to bill and get that information. So I've been using the InflammaDry test now for, since its inception. Immediately got, and I have found it incredibly valuable to the practice.
So in my practice, and I agree with you completely, Doug, in my practice, really anyone that's coming to me, whether it's a retina evaluation, cataract, glaucoma, as well as dry eye, I'm using a modified speed questionnaire. If they have a sign or symptom, that's going to trigger point-of-care diagnostic testing, including MMP9 testing with InflammaDry. How does that look in your clinic? Who are you testing? Do you test them just one time? Do you repeat the test? What does that look like in your clinic flow?
Great questions. And we also use a speed questionnaire, and it automatically triggers the standing protocol if it's at a certain level, which you select. And in the case of what I select is 6 or above, it automatically generates the point of care testing, including InflammaDry. And it doesn't matter what type of patient it is. If it is a pre-surgical patient, if it is a post-surgical patient, if it's a glaucoma patient, whether or not it's just a repeat exam and a regular recall exam, or whether it's a contact lens patient. Every patient, if they score 6 or above, then gets that. because I need to know, is there inflammation in their eye, and how that could affect, possibly on the pre-surgical patients, how that could affect their potential outcome. And one of the things it does is if it shows that there's a positive MMP9 level, it gives way to then go ahead and it justifies in the patient's mind why you would begin treatment. You're not just saying we want to optimize the surface. You're saying we want to optimize the surface because you're showing inflammation as a result of dry eye. So we find it, broad use, just like your clinic. We use it in very broad use because we want to know any of our patients if they're coming in. And then it's non-specific inflammation. So then we use our clinical skills to determine what aspect of inflammation is it.
So when you say that non-specific inflammation, what does that mean exactly? Does that mean MMP9 is present in a lot of diseases that we see, or is it still pretty selective?
Well, yeah, it is. And let's say that somebody has an allergic conjunctivitis. They would have, because MMP9s are matrix metalloproteinases released by stressed epithelial cells. And so it doesn't matter how you stress those epithelial cells. It can be from allergic conjunctivitis. It could be from a contact lens related inflammation or infiltrate. And it could be from dry eye. So you have to just kind of use your clinical skills to rule out the other inflammatory events that could cause that MMP9 to be increased. But that's where it gets that conversation started. It also answers some questions for patients that may have been feeling something that didn't necessarily bring it out in the case history, but they answered positively on the speed questionnaire.
So let's talk about a patient in your ocular surface disease clinic. They come in, they get a speed questionnaire. That triggers the point of care diagnostics upstream, correct? Your technicians are doing this test?
Yep, before I ever see them.
So you're getting data that helps you to make a diagnosis. So if you get somebody that their clinical, history and exam are really consistent with dry eye disease, or maybe dry eye disease in combination with meibomian gland dysfunction, and you get your InflammaDry back and it's bright red, I mean, what am I looking at when I try to interpret that test?
Well, what you're looking at when you're looking at that positive is there's really different levels of positive. Although it's not quantified as a clinician, I look at that and say, if somebody has that bright red line, they have a considerable amount of inflammation far above the threshold, which would turn it a faint pink. And what that does is, is it going to alter the beginning of the therapeutics for the patient? Not necessarily, because I'm going to, again, use my slit lamp and use other tools to start that treatment. But will it alter the treatment downstream? Will it change? And to answer the question, how often do I do it? Every time I've seen that patient where I feel there could be some type of significant change based on the data from the therapeutic, from the pharmaceutical companies in the pivotal trials, when they saw results, when I see that patient back, so it might be 2 months, it might be a month and a half, when I expect to see results, then I will retest again. And the interesting part I found is patients love to have the test. If you don't do it, they will ask you, are we going to do that test that where you blot the eye? Sometimes they don't know, but they know the inflammation part of it. They'll ask you because they're interested in finding out whether or not it's improving, if we're trending in the right direction.
Yeah, so I use that test a similar way. I would say it helps guide me, even at that initial one, is sometimes if there isn't a lot of inflammation or that MMP9 is negative, maybe I need to step back and say, am I really treating dry eye, or is there something else going on here? On the flip side of that, if it's bright red and it's definitely a positive test, but I look at the rest of the clinical picture and it doesn't look like dry eye, I say, well, what am I missing? Am I missing condylosis, ABMD, allergy? So I use that in combination with my patient history as well as the exam right out of the gate. But let's go back to a dry eye patient. So let's say a patient comes in, they have classic dry eye symptoms and fluctuations in vision, burning, irritation, and you do the InflammaDry and it's a positive test. It's bright red, maybe moderately positive if we want to qualify that a little bit. And you decide that this patient needs to maybe be on oral nutraceutical and something like Cequa to treat their inflammation. When would you see that patient back? Would you do the InflammaDry again for sure at that next visit? And then what would a change in that test help you do to monitor that patient?
Yeah, 100%. I'll do it again when I see the patient back. And, when we look at the data, say for something like sequel, when we would start to expect some changes, at that point, I'd have them back for that. I would do the test again. There's no limitations to doing that test and repeating the test. And what it does is, I think what's really important is when I explain to the patient for the first time that this is actually looking at inflammation. And all of this in dry eye is going to be based around inflammation. So it's really important to set the stage is I'm testing for inflammation as well as then we're treating inflammation. And that's what initiates. And so when I'm putting out any type of treatment that is doing inflammation, I'm specifically relating to that test and how we want to see an improvement, how we want to see a movement on that. You brought up another good point is what happens if it's positive, but you don't think it's dry eye. I would say the number one referral I get in from optometry and ophthalmology as dry eye that isn't is epithelial basement membrane dystrophy. And that really helps bring it out. And a story I'll tell is I have a technician that's been with me for years. So he works this patient up. He gets the case history from the patient and finds out when the patient is having the majority of their problems and start out and how their morning starts out. And then we do osmolarity, and it seems to be normal. We do inflammation, and what it's showing at that point is a high inflammation. So he walks out and he hands me the chart and he goes, $10 says it's epithelial basement membrane dystrophy. And sure enough, I walked in and I said, oh, aren't you getting kind of cocky? And walk in there and sure enough, put some stain in, it was EBMD. So, it really does help guide when you have that pause and you say, it doesn't look like this, but maybe it is. And the same is when they have these symptoms and it's really low. And, what you find often is you'll have a low MMP9 and condylosis and a normal osmolarity and a high inflammation in that as well. So you're looking at that as well. So it does help differentiate and guide your treatment, but really, really helpful in terms of saying, where are we going in this treatment from here? Do I need to increase it? Do we still have this level of inflammation? And then you start asking more questions to the patient. If that inflammation is still up and they're on a drug like Cequa, yeah, you want to find out more. You want to find out, is there something else that's going on that you're not completely aware of? So very helpful.
I think having those point of care diagnostics, this is something that happens every week in my clinic. A patient will say, Dr. Durker, how's my inflammation looking? If you're not doing InflammaDry, do you ever have a patient that would ask you that question? So they know it's a diagnostic test that we're looking at every visit to help us make decisions. So then this patient that we talked about that had a high amount of inflammation, a lot of symptoms, you see him back 6-8 weeks later. Maybe they have some clinical improvement, some subjective improvement, and some improvement in their MMP9 testing with InflammaDry. Does that guide you as to whether or not we continue Cequa, we add plugs, we do thermal pulsation? Like what are your trigger points for doing another therapy?
Yeah, absolutely. Because once that inflammation is lowered to a point, then we can consider punctal plugs. It also tells us initially we don't want to do punctal occlusion on those patients. So it does help guide that. And then it also tells you, okay, you don't necessarily need to add something else at that particular time. Maybe you just need to give a little bit more time in the treatment. So I think it really helps from the standpoint that, I'm sure you've had this experience many times where the patient comes in and they say, I think I'm about the same. And you say, well, good news is the inflammation has really lowered. When we do this InflammaDry test, we're showing that the inflammation is, and they say, that is such good news. I'm really pleased to hear that. So, sometimes patients don't want to admit to improvement. And with this test, I think it really helps to do that.
Well, I think we have to remember we're treating disease, right? So if we're treating the disease, most of the time, if we're treating the right disease, the patient's going to eventually get better. So I can look at, before I ever walk in the room, I see that MMP9 level is lower. I can walk in confident and say, hey, Mrs. Smith, this is great. Our medication is working. Your inflammatory markers are much better than they were last time I saw you. How have things been going on your end? So some of this, we want to control that conversation a little bit more, not just, hey, how you doing? How you feeling? It's, well, we're treating your disease. I did an objective test to actually monitor it. It really changes that conversation dynamic with the patient when you have that additional data point.
It changes the whole dialogue. And what you want is you want to be able to control the dialogue. And what I find, and there's recent some ASCRS guidelines where they talked about doing InflammaDry, measuring MMP9s, and looking at osmolarity pre-op to identify patients that perhaps have that inflammation and high osmolarity, to really help guide that and start that treatment and justify to the patient why you're taking that pre-op patient, why you may be holding off surgery just a little bit to start that. And I found those guidelines are helpful in our clinic to do that on all those pre-op patients. I mean, we were doing it, but it really helps to also state the position paper of the SCRS and why we're doing that and why we are perhaps holding off on the surgery.
No, I agree completely. And if you look at the numbers of patients that come in symptomatic or even minimally symptomatic in the pre-op cataract space, a high percentage of those patients are going to be InflammaDry positive, and likely that patient is going to have a better patient journey and likely a better refractive outcome if we can manage that preoperatively.
And that's what we want. I mean, whether it's the surgical facility or it's the co-managing facility, we want better patient experience. We want tighter outcomes. We want to titrate things. So absolutely. I mean, the happier we have those patients and the more justification we can give them for treating, because really, I mean, when you look at what you do for patients, and as your facility, you can do one of two things. You can either see more patients or you can do more for the patients you treat. And if you're doing more for the patients you treat, justified by a point of care test, then you're raising the level of care that you're providing the patient. You're helping out the revenue of the clinic. And those are the only two things you can do, either see more patients or do more for the patients you're seeing. And I think that the inflammatory test is one of those tests that is so easy, doesn't require capital investment, that allows us to have additional visits and be able to give a higher level of care to our patients.
So who pays for this test, Doug? Is this something that's covered by insurance? Is this out of pocket? You already talked about not having capital costs, but somebody's paying something for this test. How does that work in your clinic?
Well, the way it works is you bill it as a lab test. And the reimbursement on the InflammaDry is such that you're never really going to get burnt on the test. Certain insurers, certain payers pay better than other payers. But what I see in that with the payment, you're never left stuck holding the bag on these things. And if there's certain insurance companies that absolutely don't, what we do is we have the patient sign an ABN and ask them if they want to have this, even though their insurance company doesn't want to pay for it. And it's shocking how many patients say, yes, if this is going to help the doctor, I want to have it done. And then they pay for that. So the patient pays for it. We always hope that the insurance company will. But in the event that they have an insurance or a payer that's not willing to do that, then we have another avenue. We don't just simply not do it because of the insurance, because we consider it a valuable test and the patient understands its value. So therefore, we'll go ahead and ask the patient, if they'd like to go ahead and take care of that because their insurance company doesn't want to take care of them.
Yeah, it's pretty rare in Indiana to have an issue with payment. I mean, it's you're not going to retire doing MMP9 testing, but it is going to be a positive net to your practice. But I think the biggest thing is it helps you make decisions with more confidence, and it's a patient flow standpoint. If I don't have that information, I'm having to try to guess a little bit more as to what our next step is. So for me, it's a positive revenue, but it's more of a positive clinic flow to help me make a better decision for my patient.
Well, and also I think you really have to remember it leads to more downstream procedures. It leads to more microblepharoexfoliation. It leads to more thermal expression. It leads to more IPL, because if you still don't have those levels down and they're on an anti-inflammatory medication, then you have to go to the procedures, and it justifies that. That's what's so nice. You say, now we really have to look at this. We're just not getting the inflammation lower enough with this, so we're going to have to look at other types. So my feeling is, if it was a break even, I would still do this every day on every patient, just like I'm doing it, because of what it leads to in patient confidence and being able to look and say, I'm making this determination on this recommendation of what you need for your treatment based on a point of care test. So, and it's not just a break even. It does create a positive cash flow. But I feel that strongly about the point of care test, that if that was just, simply a break, I would still do it because it leads to a lot more treatment of those patients.
Yeah, in my clinic, it's a pretty easy equation. MGD plus a positive InflammaDry generally equals IPL. It's that easy, right?
That's
Look
the
at
same
little
calculus I use.
angioplasia. That's it. I mean, that's going to be huge. And then you treat them with IPL. Boy, that MMP9 looks so much better. It's great to see. So we're going to wrap up here, Doug. Thank you so much for joining us, talking about InflammaDry with Quidel. Obviously, they have the QuickView adenovirus test as well. Any final thoughts, Doug?
No, I really appreciate this opportunity to share this information with colleagues, because I think this is something with point-of-care tests that we really need to embrace with optometry, and that is, letting point-of-care tests help guide and help treat our patients. I just think it's a good addition to the clinic, and it can be worked in. And you've done it in your clinic, I've done it in my work. It can be worked in, and it really doesn't disrupt the flow. You can just get it to the point where it just kind of flows, and ultimately it's going to benefit the patient. And when it benefits the patient, it's going to benefit your practice as well. But thank you for having me today.
Agree. Take care, Doug. Good to see you.
All righty. Good to see you, Damon. Thanks.